What's up, y'all? This is Dr. Hall and AKA Dr. J. We're going to talk about this case report that I talked about previously. This is part two of this 18-year-old gentleman who presented to my clinic with acute kidney injury, hematuria, and proteinuria. I think it's a really good learning case for you guys. My job as a nephrologist and with this platform, I want to help you bridge the gap from medical knowledge to clinical application. How to take all that information that's in your head, and when you see a patient, you know exactly what to do, especially if they have kidney issues. This is my primary modus operandus. This is what I've been doing for a long time. Probably about 20 years. We have our own practice here in Brookhaven, and we do dialysis. We're hypertension specialists, board certified nephrology, internal medicine. So we get a chance to see a lot of really good cases. And so I want to try to continue to give you guys these case reports so that you can kind of bridge that gap from what's going on paper to what to do with my patient when they come in. One suggestion I have is always look at labs before you see your patient. Always have a little idea of what you want to do before they get in clinic. And if you have time, try to read a little. If you know the patient's got proteinuria, read up on proteinuria. If the patient has hyperkalemia, read up on hyperkalemia. This will give you just a little bit more confidence in talking to your patients and managing your patients when they see you in clinic. We have an online course that we've created. We also have a free webinar that I would love for you to check out. It's loaded with this type of information: clinical cases, medical knowledge, how to bridge that gap and time together so that we can better help our patients. So on to my case here. This guy's an 18-year-old gentleman, and he has, like I said earlier, he presented with acute kidney injury originally, and his creatinine was 1.43 at that time. So we saw him when he saw his primary doctor, and I think he went to the ER originally. He was dehydrated. So we saw him about a week or two later from that incident, and his creatinine had dropped to 1.18. So it went from 1.43 down to 1.18. When you see that, that lets you know that he probably was dehydrated. He probably was somewhat hypovolemic and just needed some water, needed some fluids. And we live in Mississippi. It's always hot in July. So I wasn't really that shocked to see this patient had an acute kidney injury from, just poor intake, dehydration, and that type thing. That's real common. But the one thing that I wanted to help you guys look at and understand was his serum albumin was 2.0. On the original chemistry that was checked, comprehensive metabolic panel, it was 2.0 grams per deciliter. And then one in my clinic on last week, it was also 2.0 grams per deciliter. Well, what does all that mean? Well, it could mean you got liver damage, like we talked about in the previous thing. It could mean you're malnourished. But in this guy's case, most likely he's losing albumin in the urine. He has some type of glomerular injury that's damaging his glomerular basement membranes and causing him to lose protein, albumin, in the urine. And that makes his serum albumin low. A young black male, well, he's a football player, remember? He's eating really good, so he's not malnourished. So my job as a nephrologist, your job as a primary care provider, is to quickly find out what's going on with this guy. The other thing is he has a little bit of blood and a little bit of protein. So those two things make me think glomerulonephritis. When you see protein in blood, I know urinary tract infections can cause that, but honestly, that's not what I mainly focus on. My focus is what can damage your kidneys permanently. UTIs are easy to treat. You guys know how to treat that, how to manage that. So I'm not going to really get into that in this video. My main focus is to try to help you figure out what's going on when you see blood and protein in the urine outside of a UTI. I think glomerulonephritis. Something has acutely damaged the kidneys, either an inflammatory reaction or some other type of reaction that's causing the patients to have glomerular injury, which is where the blood comes from, and damage to that glomerular basement membrane, which is where the protein is coming from. So what do? We check the ANA, anti-nuclear antibody screening test. His was normal. We're looking for lupus or some other type of connective tissue disease. It's raining outside, so I hope the background noise is not bothering you too much. We checked the HIV. Remember, the third most common cause of kidney disease in blacks age 18 to 64 or 25 to 64 is HIV nephropathy. So we always check it. His was negative. We checked an acute hepatitis panel because it can cause a severe acute nephritis, glomerulonephritis from hepatitis. His hepatitis panel was negative. We checked the immunofixation electrophoresis just to see if he had any abnormal proteins that he was producing that may have been causing some of this, and his was negative. So his serologic workup was fairly normal, which is very just encouraging to me that it's nothing like that. So what's next? The next thing we got to do is get an ultrasound on this patient. We got to get an ultrasound to find out, is there an obstruction? He's young. Younger patients sometimes can have a congenital abnormality such as reflux issues, reflux nephropathy, that could have potentially caused you to just have chronic urine reflux in the kidney, which can cause protein in blood. Kidney stones can cause protein in blood and urine also. He was not having any pain, but that's another thing you want to look for. And then urine protein to creatinine ratio. So it was not repeated. For some reason, we don't have it back yet. But we did order renal ultrasound. We did order a urine protein to creatinine ratio. And we did repeat a UA on him. These are the three pending things that I got to get on him to figure out, okay, without being too invasive, what's going on. Next is the genetic testing, which is still pending. And we also plan a renal biopsy. So this is going to be a really good case for you guys to help us tie it all together and for me to teach you guys how to take all that medical knowledge and put it into clinical practice. This is part 2. We'll be coming back with part 2 probably in a week. He should be getting his biopsy 2 or 3 days from now, as well as the other tests that are pending. And so I will re-inform you guys, re-update you guys on what we see when it all comes back. Thank you. We appreciate you tuning in. Check us out in our free webinar. See you in the next video. Bye.